Oh my goodness. Okay, so I guess Dr. B, there's a couple of people in the waiting room.
Okay. I'm going to try to log in.
Okay. All right.
That's what, if you talk into my wallet for now, that's why I wouldn't let me open. It would say I didn't have the authority.
Okay. Oh, the VPN. Ay, ay, ay. Well, I should be okay on Zoom, but if I need to get to my email, I won't be able to.
Okay. What about on your phone? Do you have your phone?
Well, no, I'm on the Zoom, but yeah, so it just makes it harder if I have to move around too much.
No, like if you want to log in, like check your email on your phone.
Yeah, I can, but if I'm gonna, yeah, I can.
Okay. Is it an issue? Like I'm just trying to make sure.
No. I'm just saying my VPN. No, I'm just, yeah, no, it's okay. It's fine.
Okay.
Earrings. I wonder if it's making Dr. B read as well. Admit. I got one earring. I did. Oh, I let the wrong person in. Who's Janice Fitzgerald? Where are you? I let the wrong person in instead of you. But now you should be joining.
Okay, recording in progress.
So I'm gonna upload Dr. B's slides into Drive right now.
No, Drive is gonna be too challenging for me to get into. So she said she would just advance them herself. Because
okay.
I couldn't get in for whatever reason. When she said she tried to let me in, it wouldn't give me access.
No, not Box. Google Drive.
Right, so I can't access Google Drive from the computer I'm doing Zoom from. I would have to go to the other computer. So let's just go ahead. Yeah, I think she said, Dr. B, are you in?
No, it's just the three of us here.
I clicked let her join, admit her. Let me do it again. Admit. There we go. I'm over here admitting the wrong folks. Hey, Ashley.
Hey, Shut.
We're usually, Frances and I are usually on the call like 45 minutes before. So all kinds of challenges today. Hi, Dr.
Can you make me the co-host for Shut?
Hey there.
Good evening.
Good evening, Dr. B.
Good evening. I'm gonna grab my tea. I'll be right back.
Okay.
I sent you the PowerPoint if you want to, but like I said, I could totally do it. Not a problem. Okay. But you should have it in.
Do you want me to read everyone's bios, or will you kind of do like an intro? Or
no, you go ahead and do the bios. I'm trying to do minimal. No, I'm just playing.
Hey, that was my line.
It is the end of October. I'll be back.
Okay, Frances, where are you?
I'm here.
No, I was just trying to figure out where your name was. So then I'll have to make Dr. B the co-host, right? And I'll have to remember that I have to do that.
Yeah. Did you make Ashley a co-host?
Well, you can only have two co-hosts, right?
No, I thought Ashley said it's unlimited.
Oh, look, that's what the internet said, but we know the internet is not always correct. but that's what I saw on Google. But I don't, the internet is sketchy at best.
I didn't even have, okay, where's Ashley? Let's see, make Ashley co-host. Let's see what happens.
Can you make me the host, Plachette?
Co-host. Ashley, can you see if you're the co-host?
And how would I do that? Let me see.
When you look at your participant list.
Okay.
So it says Vivian, it says Dr. B is co-host, Ashley is co-host, I am nothing, and Frances is host.
Okay, so now you have to co-host me then, Plachette.
Or Frances.
What'd you say, Plachette? You're breaking up, Plachette.
Breaking up, yeah. God, I pray for their family. Oh Lord.
Push that fall off?
I hope not. Let me see. Let me go to the participant list. Yes, she did.
Okay. I'm going to start letting people in. I have this up for the time being. I'm going to start letting people in. Can you watch to see when she gets back in here?
Yes.
I don't even see her on this list. Oh, let me let in Dr. Balogun. And okay. Let me call her because I don't know what happened to her.
Okay.
Hi, Dr. Balogun and Dr. Taiwo.
Hi, how's everyone?
Hello, how are you?
I'm good. I should let me change my background. I like your background.
You want me to email it to you?
Yes, please. I was on mute. How have you been? I feel like I haven't seen you guys in forever.
No. Same.
Oh.
It's been forever.
So, Shat, what happened?
Hi, Dr. Taiwo.
Hold on, I don't see anyone. It's not video. I don't know.
So, Princess, tell us what I know Placette fell off, but can the show go on if needed?
Yes, we can. We can have the show go on. Placette, can you try to log in through something else?
Because it sounds like she's got spotty internet, so.
Okay. Okay. All right, so then let me pull up the bios and I'll start the introductions.
Okay, and then once you do the introductions, then we'll take it over. Is that how we're doing it? And then maybe that'll give her time to come in and do what she needs, whatever. Y'all tell me what you want.
Okay, yeah. Okay. All right.
Hey, Placette.
Do you see her?
Not the same background. I don't know what happened to that background. We can't hear you, Plissette.
You can see her?
I can see her.
Oh, okay, perfect.
She's on the list for the participant list, but it has
I sent you something else, Dr. Balogun.
Yeah, Dr. Balogun and Dr. Evelyn is not listed as host or co-host. So just wanted
you guys
to let
can't
you know
see me.
Well.
You guys can't see me or hear me. Hello.
I can see you. I can hear you.
Okay.
Yes.
Okay. So now my So we're doing welcome art. Did we do the poll? No, right?
No, I just want to make sure that I can share.
Advance the slides. Okay.
Yep. Can y'all see that?
Yes.
Okay. All right.
So Francesca, you still want me to put up the other slides? I have them.
Yeah, you can.
Okay.
I was just looking for the bios since you got knocked off. But since you're back, yeah, you can put them up.
All right. I want to let people in.
Yeah. Lashette, you ready?
Ready?
You're recording, right?
I'm ready. Diane said, hey, I'm in the waiting room. Who's letting everyone in? Is that me?
I'll do that. I'll do it. You guys ready?
Okay. Yeah.
Plissette, is that your? Are these your slides, Plissette? No.
These are the slides that you created. No, that's not.
No, you don't have to show them. We can just go straight into the ones that you have, the agenda. All right, let me.
Plissette, you're breaking up. I'm gonna mute you. You're breaking up.
All right, I'll let everyone in, and then okay. Ashley, do you happen to have the bio email on hand?
It's okay. We can introduce ourselves.
Okay.
All right.
Right.
No problem.
Because this, yeah, and we've also allowing American staff to choose a different vaccine brand for booster.
Greetings, everyone. We're going to just give everyone a moment to come in and we will start our program. Thank you so much for taking the time to join us. I am Dr. Vivian Bea. So let's give it another minute and we will get started. Okay, I know we have a few more to wait. I'm going to ask that everyone mute yourself when you come in, please. Fantastic. Okay. All right, let's get started. Welcome to the Pink Table Talk, this wonderful Breast Cancer Awareness Month. My name is Dr. Vivian Bea. I am a breast surgical oncologist at New York Presbyterian Brooklyn Methodist Hospital. I am also an assistant professor of surgery at New York Presbyterian Weill Cornell Medicine. And one of the co-PIs for the grant that has sponsored some of these education events through the American Cancer Society. And I want to pass the mic over to one of my two wonderful, or should I say, fabulous colleagues. I'm going to start with Dr. Ani Balogun so she can introduce herself. Dr. Balogun.
Did you try to?
Good evening, everyone. Thank you for a wonderful introduction, Dr. B. It's always fantastic for me and a treat to speak with you two ladies who I respect so much, and to also get a chance to talk with all you wonderful people who've taken the time to speak with us. I'm a breast radiation oncologist working at New York Presbyterian, Brooklyn Methodist, and I have a passion for also addressing disparities like Dr. Bea and Dr. Taiwo. So I look forward to speaking with you all more tonight.
And Dr. Taiwo?
Good evening, everyone. My name is Evelyn Taiwo. I'm a medical oncologist at New York Presbyterian Brooklyn Methodist Hospital, also assistant professor of medicine at Weill Cornell Medicine, Medical College. I work closely with Dr. Bea and Dr. Balogun. Very excited to be here tonight talking breast cancer, educating everyone, and then it's always nice to be with people out in the community. So I'm looking forward to this time with everyone.
And so let me just start by saying, giving a special shout out to all of the community partners that we work with in Brooklyn and in Camden, New Jersey. We're excited to do this. And this includes, again, the churches, community outreach programs, as well as sororities. I know we have some sorority sisters here. So shout out to my sorority, Sigma Gamma Rho. But I know we have others, AKA Delta and Zeta. So welcome tonight to our Pink Table Talk. We really wanted to take the time, as you know, this is Breast Cancer Awareness Month. And so we have been sort of on the tour and giving talks and presentations throughout the month. And so this presentation is not meant to be heavy or boring. It's really meant to educate. And so I want to encourage you to hold your questions. We're going to try to get through our presentation, put them in the chat. The chat button is right there. And I promise we will do our best to get to them, okay? So I'm gonna go ahead and share my screen and you should see it momentarily. Here we go. All right, again, welcome to the Pink Table Talk. This is Facts and Myths about breast health. So I always like to start with statistics because it's important to really show you, what we know as far as data is concerned. We know that in the United States, for women, breast cancer is estimated to be the #1 cause of new cancer diagnosis. And when we look at the estimated cancer deaths in the United States for women, breast cancer is the second leading cause of cancer-related deaths. And so it's important that we focus on it and we, discuss some of the ways to screen and sort of be proactive. One way, and this is so important, and I know that many of you have probably heard it, but I like to add pictures, is to really be familiar with the signs and symptoms of breast cancer. And you may have heard that if you feel a lump on your breast or underneath your armpit, we call that the axilla, then that would be a reason to go and get checked out. There are other signs and symptoms, however, that we don't often or always talk about. And so I wanted to show you some pictures here to give you an idea. So if you have a change in the size or shape or color of your breast, that would be a reason to go see a physician. If you have swelling and thickening, sort of like, I don't know if you can see my pointer right here, that would be a reason to go see a physician. Nipple discharge, and the discharge can really be any color. It could be bloody, brown, green, clear. That's a reason to go see a physician. If the nipple actually goes in or retracts and had not previously done that, meaning you weren't born with a nipple retraction, another reason to seek attention. If there's skin irritation or dimpling, and again, the lump under the axilla or armpit, those are reasons to go seek attention. So when I look at the statistics, I want to point out that, part of what we do is we serve all women. But we know that in breast cancer, especially because of COVID, you know, COVID shined the light on disparities. And, but in the breast world, my colleagues and I were well aware of disparities in breast cancer care. And so we always take a moment to talk about those disparities so that you are equipped, whether you are a minority, a Black woman, a Hispanic woman, or even a white woman, understanding what those disparities are can empower you and the ones that you love. So the trends in breast cancer incidence, we know that in the United States, the top line is white women and the bottom pink line is Black, that while the incidence or the occurrence of breast cancer diagnosis is slightly lower for Black women, that there's actually a 40% disparity in the mortality or death rate in Black women. And this is due to many, many factors, but we really saw that division in survival for white and Black women in the late 1970s, early 1980s with the advent of tamoxifen, which is a hormone pill that sort of treats hormone-positive disease, which is more common in white women. And then so lots of research and questions were had, and we found out that Black women actually are more likely, twice as likely to have hormone-positive disease or a triple-negative disease. And so that pill didn't work for Black women. And so what we know is that because of this, it's even more important for us to educate that screening is important, mammograms are important, and understanding what's fact and what's not fact in your breast health is important for us to talk to you about, so that, again, you can arm yourself and ensure that your friends and colleagues are aware of ways to advocate for themselves. Now, the breast cancer crisis, disparities crisis, is due to many factors, but we're going to focus on screening and myths today. So let's talk about breast surgery. I'm a surgeon, so I'm going to start out. I realize that I'm doing a lot of the talking, but trust me, I'm going to get to my wonderful colleagues who are amazing after the surgeon goes. We like to go first. So, so here we go. Myth, or is it a fact? If I get breast cancer, I have to have my entire breast removed. Do you have a poll, or am I asking for too much? Can you pull up the poll, Princess? If not, don't worry about it. But with a show of hands, let's do that. Is this myth? If it's true, raise your hand. If it's false, raise your hand. Y'all aren't participating. I don't see anybody. Do y'all see? Okay.
Yeah, people have their hands up. They're using a little. Okay. They're Zoom savvy.
They're Zoom savvy. Fantastic. So we know that the fact is that if you have breast cancer, it does not mean that you have to have your breast removed, your entire breast removed. Not always. So in fact, we know that back in the day, mastectomy was the only option, and it was quite morbid, quite frankly, with not great survival. And then over the years, we learned that we can actually be more savvy in the breast surgery that we offer, such that most patients have the option, I shouldn't say most, some patients have the option of either a mastectomy or a lumpectomy, where we take the cancer in a clear rim of cancer-free tissue with radiation, and they're able to conserve their breast. So that's called breast conservation. Now, some patients say, I want to have my breast removed, and I understand that I'm a candidate for breast conserving surgery or a lumpectomy, and that's completely fine. There are some patients who are not candidates for breast conserving therapy, but it's not a one-size-fits-all, meaning just because you're diagnosed with breast cancer does not mean that automatically you will have to have your breast removed. Fantastic, and we have a poll, so we'll do it for the next question. Question. So myth number 2, if I have surgery for my breast cancer, the cancer will spread. I want to see what the audience thinks about this. Is that true or false? And I'm going to give it a few seconds.
This is definitely one that I've heard from people, because they think that maybe if it's exposed to the air, that it might spread that way. So this is a good one.
Right. And it's also, I'm going to replace surgery with if I have a biopsy, because I've heard that most recently. If I had a biopsy of my breast, then the cancer will then spread. Okay, so I don't know how to interpret the poll, but it looks like it's pretty mixed. So I think that's good. Good that we're bringing this up. So Dr. Balogun, do you want to tell them why this is false? Or that it's false? So it's false.
Yeah, it is false, like you said. I mean, I think like you mentioned, the biopsy, when we take a sample, usually we poke a needle in, and we have to take a sample so that we know what kind of cancer it is, right? You talked earlier about the hormone positive cancer, the hormone negative cancer, but we have technologies, techniques that do not spread the cancer. That's not what makes the cancer spread throughout your body, just getting a sample or taking the tumor out, even though I'm sure it seems to some people, maybe they've heard stories where that was the case. Yeah.
I think that, and I think that if we think about historically, where this myth may have come from, back in the day, our great-great-grandparents, we didn't have CT scans. We didn't have ways of screening for cancer. And so cancer often presented at a more advanced stage. While we may not offer surgery for a more advanced stage, surgery was offered and the cancer has already progressed. And so we're not there now. Now we do have ways of looking at the body with CT scans and again, screening with mammograms so that we have a better idea of how advanced one's breast cancer is. So this is not fact at all. So having surgery, having a biopsy will not spread.
Recording in progress.
I never thought about where it came from, but you're absolutely right?
Right.
You couldn't see inside and people thought, oh, this was what triggered it spreading when it may already have spread. So Good point.
Absolutely. So myth or fact, this is a good one, Dr. Taiwo. And so let's pull up the poll. The question is, if I don't have a family history of breast cancer, I won't get breast cancer. So we're going to give it 10 seconds. Oh, I'm loving what I'm seeing. All right, Dr. Taiwo, you want to take it over?
Yes, I'm going to go with the audience. So this is a myth, so it's false. So actually, most patients who are diagnosed with breast cancer don't have a family history of breast cancer or any cancer. There are cancers that do run in families, but in general, it's only about 3 to 5% of breast cancers that are actually associated with, a family history or something inherited. So this is false. So a negative family history is not a reason to not get screened and be aware about the need to, follow up and pursue any concerns about a possible diagnosis.
Absolutely. All right. Let's go to the next question. If I can get my computer to work. There we go. Okay. Using underarm antiperspirant can cause breast cancer. Is that true or false? So it's interesting. I'm gonna let y'all answer, and then I'll say that this question has come up quite a lot. I've been on radio stations and different talk shows, and I can tell you I got this question a lot, which is why we put it here, because we know that there's some information out there. So, and look, it's the poll shows that this is a question that we need to absolutely address.
I think even you might substitute cell phone for antiperspirant, right? Mm-hmm. So putting it close to your breast, or, in some cultures, women who might sell things in the market might put money right, that might be dirty next to their breast. So if you interchange any of those things, we need to talk about, does that cause breast cancer?
Right. So let's share the results. And so about 2/3 of attendees think that this is false. However, 1/3 thinks it's true. And there's a reason and a cause to be to have confusion. Okay, so there have been some recent reports that the aluminum in deodorant can cause breast cancer, but actually there's no strong study, evidence-based, peer-reviewed study, which when we look at research, we actually look at it in a tiered sort of way. And so there's no strong evidence to actually support that. With that being said, I am pro do what you love. Okay, if you want to not use deodorant, if you want to go natural, have at it. I actually strongly believe, and again, this is not evidence-based, that anything of too much is not good, right? So, have a vacation from, your deodorant, but it does not, there's no evidence to show that it actually leads to breast cancer. So that's my answer. And then, the cell phones, we're actually going to get to that one as well a little later. So let's share those results. Okay. The next question is, if I maintain a healthy weight, exercise regularly, eat healthy, and limit alcohol, I don't have to worry about breast cancer. Let's launch that poll.
Ooh, that's a demanding lifestyle. Y'all know I love ice cream, so.
I hear you. Fantastic. Oh, we're on a timer. Okay, good. I'm going to end it now. All right. So who wants to take this one?
Do you want me to?
Yeah, have at it.
Okay. So obviously there are many, healthy and good behaviors that, improve our health, and improving health also leads to risk reduction. But all these things are risk reduction behaviors, right? So limiting the amount of alcohol that one takes, keeping a healthy weight, being active, reduce the risk of breast cancer and other cancers, but they don't eliminate, cancer. We know people who are very healthy, who've never smoked, who've never done anything. They're squeaky clean, who still develop cancers. And I think it's important so people know that there's nothing for the most part that one is doing that's causing you to have cancer. Most times it happens for whatever reason it happens, but there are things we can do to reduce the risk. So healthy behavior reduces the risk. It doesn't eliminate it, which is why we also recommend screening. You can engage in those behaviors, but it doesn't eliminate it. So that's also false. I think the audience is onto our poll now and our myths and facts.
Okay, there you go, Dr. Balogun.
This one. So,
yep.
Yeah, exactly. So there's no connection.
Yep, there's no connection. There's no evidence to support that. Okay, and this is kind of what Dr. Taiwo was talking about. Consuming too much sugar causes breast cancer. So, okay, you don't have to stop your sugar. We know it's the holidays. We don't even have to put the poll up. I'm gonna go ahead. Oh, put the poll up. Look, there. We're gonna put the poll up. Okay, so there's no evidence that sugar in the diet causes breast cancer. But again, anything of too much is not good, right? We know that that sugar can lead to, as we call it, sugar, right? Diabetes. And so and it can also lead to being overweight and obese. And we do know that being overweight and obese contributes to even breast cancer recurrence for hormone positive breast cancer. And so anything of too much is not good. So we want to limit, but not exclude completely. You don't have to exclude your sugar. Okay, annual mammograms guarantee that breast cancer will be found early? That's a good question. Let's launch that poll.
I think I would even ask you the question, I've heard that some people say I shouldn't get it every year.
Correct. So
the mammogram every year.
That is a great, so let me pull up this, and I'm going to show a chart that's going to address that statement. So although getting a mammogram is the best early detection tool, it doesn't always find breast cancer at an earlier stage. And so it sounds counterintuitive, but this is why we say continue your mammogram, because some cancers are difficult to find even on mammogram. And but we also know that when we do a mammogram, even if you've gotten it every year, sometimes you can have a tumor that has grown, grown fast, and now it's 3 or 4 centimeters. So yes, we want you to get your mammogram, and this brings us to the point that recommendations are confusing, and I'm going to take a minute on this, and I'm going to ask my colleagues to jump in because it's so very important. So it can be confusing because primary care physicians and certain other physicians, there are different guidelines and different bodies or consensus statements that we follow, unfortunately. And there is one set or body of guidelines that may say, start your mammogram at the age of 45 or even at the age of 50. And there's another that says, or the same one that says, and you can get a mammogram every couple of years as opposed to every year. But if we're going to go back to what we talked about earlier when we said disparities exist, that we still have deaths due to breast cancer, breast specialists, most breast specialists, and all of my colleagues here agree that having your mammogram at a later age and having your mammogram every 2 years as opposed to every year is not the answer. Okay, that is not how we're going to win the war on breast cancer. I should also mention that for Black women, breast cancer is more likely to be diagnosed at an early age. Okay, and so even before the age of 40. So how do we combat that? Well, I love the fact that the Society of Breast Imagers came up with recommendations that support annual mammography screening starting at the age of 40 for one. And by the way, they're joined with a handful of other recognized societies. So the American Society of Breast Surgeons, the NCCN guidelines. So they all agree that you should start at the age of 40 for average risk, if you're average risk. Now, how do you know if you're average risk or you're high risk? Well, they're now recommending that all women should have a risk assessment at the age of 30. Okay. And even earlier, if you have a significant family history. And so that means, and especially, it says especially minority women, to ensure that they are not at a high risk for breast cancer. So we have to get the word out that, your cousins and your daughters, if they're over the age of 30, they need to have a risk assessment to determine whether they need to even start screening before 40, or maybe you need to start screening before the age of 40. I also will take the moment to say, if you are over 75 and you hear a physician say, or an NP, a provider, whatever, say, stop your mammograms at 75, we also don't support that. what we say is that if you are at an age where you're willing to receive therapy and able to receive therapy if you're diagnosed with breast cancer, then go for it. I'll give you an example. My grandmother is 92. She's a good 92, like a good 92, like, okay.
Go ahead, Grandma.
Let me tell you what her first, she thinks she knows she's cute. She knows she's cute. She knows she's cute. But, she like so many other 90s the new 70s for some people, right? So get your mammogram if you're willing to get the treatment. And I will tell you that I have operated on patients who are in their 90s who walk into my clinic and walk on out by themselves. Okay, so pass the word on. The other point that I will make is that we also believe that doing breast exams are important because you are your best advocate, and you can learn your breast. Now, there's some societies that say no, don't do that, but I have patients who come in who have found something that that wasn't there when they got the mammogram, and so instead of waiting through that whole year, they were able to pick up a breast cancer. So do your exam. Anything else to add?
So we had a question in the chat from Miss India Sneed. Thank you for joining us tonight. Does having a personal history of cancer, specifically cervical, make one more at risk of breast cancer? So I think maybe you're thinking about it along the lines of like, if I need to start screening, maybe I have a history of cervical cancer. Does that now mean that I have a higher risk of breast cancer? I need to start screening earlier. And I think there's certain cancers that you get, especially if someone young in your family gets that cancer, where you should do something called genetic testing, right? So we would check your blood to see if there are certain changes in your DNA. DNA is, basically what tells your body how to make cells, how to make your body, how to make your organs. And it's contained in all the cells throughout your body. And there are some people who have changes in their DNA that make them more likely to develop cancer. So off the top of my head, I don't know of any changes in DNA that make you more at risk of breast cancer if you've had a history of cervical cancer. Cervical cancer tends to be more tied to something called the human papilloma virus. But if someone in your family, had breast cancer less than 60, right, Dr. Taiwo? Is that what would tip us off, less than 60 and a male breast cancer history?
In terms of potential inherited breast cancer risk. Well, so actually less than age 50, any male breast cancer, multiple family members with not just breast cancer, ovarian cancer, cancers of the gynecologic tract, fallopian tube. So sometimes skin cancer, colon cancer. We're focusing on breast cancer now, but there are multiple cancers that are tied to certain abnormal genes. Cervical cancer is not one of those. So generally you don't think of a higher risk of breast cancer if one has a personal history of cervical cancer.
All right, and there was another question, and Dr. Balogun, maybe you can answer this. What signs should you look for cervical cancer?
So cervical cancer, things that you might notice are painful intercourse, like if you're having sex and it hurts, bleeding, maybe bleeding when you're not supposed to be bleeding. If you're a woman who hasn't gone through menopause yet and you notice that you're just bleeding in between periods, that might tip you off. If you've gone through menopause and you're bleeding, any bleeding, I'll say this again, any bleeding after menopause, vaginal bleeding, needs to be investigated. I've seen too many women who their doctors just said, oh, you magically now have fibroids. Maybe you had a history of fibroids, but even then it needs to be investigated. So vaginal bleeding, painful intercourse, bleeding after intercourse. And, you know, I hope this isn't the case, but sometimes just pain, like back pain, if the cancer has progressed some more, having back pain can also be an indication of cervical cancer. So those are some of the signs that you should watch out for. Make sure to get your pap smears. That's the best way we have of detecting cervical cancer early. And it really makes a big difference because this is a curable disease if found early enough.
Fantastic. And we have a number of great questions coming in. So I'm actually going to stop and ask a few of them, and then we can proceed. So the first is, can breast cyst turn into cancer? And so that's a great question. Breast cyst, and when we say cyst, we should be defining it by not someone just doing a breast exam. So actually, I was talking to my sister who was telling me about what her doctor told her, and I laughed so loud. I said, she's right. You know, when you have someone who gives you a diagnosis, but there's no fact to back that diagnosis up with, then it's just an opinion. So,
okay.
Hashtag truth.
Yes.
So, hashtag facts. So if we're calling the cyst a cyst because you had an ultrasound that called it a cyst, then I support that, right? Mm-hmm. Then that is a fact, not an opinion. And cysts are oftentimes, most often, benign. Now, the cysts there are different types of cysts, and the way the cyst looks on ultrasound to the breast imager helps determine whether there's a potential for malignancy. So an example would be a septated cyst. Oftentimes we'll biopsy that cyst or pull the fluid out and have it analyzed to ensure that there's no atypical or abnormal cells. With that being said, when we look at just benign cysts don't turn into cancer. But if you had that atypical cyst, then yes, that could progress. Again, that is very uncommon. There are other, by the way, high-risk lesions that we know have you at a greater risk for developing breast cancer. Those are often found on mammogram and a stereotactic biopsy that is performed after you have your mammogram. If you call back for a biopsy, that's called a stereotactic biopsy. And those are atypical ductal hyperplasia, or ADH, lobular carcinoma in situ, or LCIS. Anything atypical, that would be something that we want to sort of look at, and we know that you have a slightly increased risk compared to the general population. Not as high as having a gene mutation like a BRCA. And that brings me to the genetics question, Dr. Taiwo, and that is, should you get genetic testing if your first cousin had breast cancer?
I mean, that's a very good question. I think there are many factors and many reasons why one should get genetic testing. I think without knowing the history of this person's breast cancer, without knowing the age of the person, without knowing the type of breast cancer the person has, it's really difficult to make a recommendation. But I mean, it's a great question. I think mostly when a person is diagnosed with the breast cancer, if there is an indication that that person should get genetic testing, the person with the cancer generally is the person who should get the testing done first. And whatever the findings from that test shows, then really guides what needs to happen to other family members. So that would be my answer, that not necessarily going out there and getting genetic testing because there's a family member with cancer, but maybe that person needs to get tested, and that may then mean everyone else in the family should get tested if something abnormal is found.
And to that end, that's very helpful. There are two more questions. One is, does having a personal history of cancer, specifically cervical, make one more at risk of breast cancer? And the other question is, actually, we'll leave it at that.
I think we touched on that one just briefly, saying that, cervical cancer, usually that's more so linked to human papillomavirus. And, you know, also having, if you have had a history of other sexually transmitted infections, then you have a higher risk of cervical cancer, but not necessarily breast cancer. And I think, you know, Dr. Taiwo touched on like other cancers, right? That might, you might suspect that maybe there's something going on in your family: pancreatic cancer, male breast cancer, skin cancers, right? I was listening, Dr. Taiwo.
I'm going to ask two more questions, and then I'm going to ask our wonderful outreach coordinators, Ms. Wiggins and Ms. Antone, to just post any ones that we missed and just ask us if we've missed it. But two that are related that I can answer are: how do we distinguish between a lump that could possibly be something of worry and clogs due to breastfeeding? And the other one is, I just saw it. How do you distinguish between, no, that's what I just read.
Do microwaves increase your risk of breast cancer?
Not that one. There's another one about, I think it's about how do you know basically if a lump is of concern? So I'm going to put those two together. And so when you're breastfeeding, you absolutely can develop clogged ducts, and those are painful. I don't wish it on anybody, but you know, you should still see a breast specialist. You should still see someone who can help manage that. That would be a reason to have, you know, a mass and not be as concerned. But with that being said, women who are pregnant and who have babies absolutely can still develop breast cancer. And so that's why we want you to see your primary care physician or a breast specialist. With that being said, outside of the world of pregnancy and delivery, because your breast changed so much, you know, when you're not pregnant and you haven't just delivered, this is why we say do your breast exams every month and even more frequently so that you can learn your breast. I had a pediatrician who did not play games. And when I was, you know, a tween, she taught me how to do a breast exam. Yeah. And, you know, and when I felt something, I would go and show her, and she, you know, empowered me to know that that's fun, that's what she wanted, and that that I should know my breast. And so, yeah, you know, young women are going to have cystic breast, you know, lumpy breast. It's harder to tell what is important or concerning versus not. But once you learn your breast, then you know when something else pops up, then that's not normal.
Yep.
So that goes back to the more frequently you do it, and the more you know your breast, the better of an advocate you can be for yourself. So that's how you learn the landscape of your breast. You go and you see a physician, and they may do some imaging, and then you know, okay, that's fine. That area is fine. But if it changes, you need to have it reevaluated.
Yep.
So Dr. Taiwo, I think we're going to move into the medical oncology section. So there are 2 slides, and then it goes into yours. So the myth is all breast cancer is treated pretty much the same way. And you want to talk about this?
Sure. I mean, so I think we all kind of see the pattern here in terms of the myths and the truth. So this is a myth. All breast cancers are not treated the same. The treatment really varies depending on what type of breast cancer one is diagnosed with, what hormone receptor status the breast cancer is, the stage of the breast cancer. It's important to for people out in the community to know that a breast cancer diagnosis doesn't necessarily mean the most aggressive way of treatment. I've had patients who, for fear of what you may recommend, don't show up, and you have this cancer's progress, and you go, oh, I wish you had come in when you initially got diagnosed, because what we would have done at that time was a very simple have you see a breast surgeon and maybe just an anti-hormone pill or whatever you may. So yeah, all treatment is not the same. And even within the same type of breast cancer, the age of a patient, the comorbidities, the underlying medical problems they may or may not have also guides how we treat a patient. We try to really personalize it. So that's important to know. Can we go to the next slide? Because I know Dr. Balogun has her own slides too, so we'll go through this very quickly.
Take your time. It's good information.
Yeah. So the next myth is that there's only one kind of chemotherapy and it can treat any kind of cancer. That's a myth. Actually, when we say chemotherapy, I think people have an idea of what chemotherapy is. Chemotherapy really is just medication. There are different forms of medications that we use for breast cancer. Sometimes it's a pill, sometimes it's actual chemotherapy that's destroying cancer cells. Sometimes it's targeted agents that we call monoclonal antibodies. Sometimes it's a combination of both. So there's not one chemotherapy, the same way there are different, blood pressure medications for hypertension and different types of medications for diabetes. There are different types of chemotherapy drugs for breast cancer, and we choose the chemotherapy based on the type of breast cancer. So the chemotherapy that's being used for breast cancer may be very different from the type of chemotherapy that's used for colon cancer or pancreatic cancer. Same thing, going back to just, personal experiences and patients in the hospital and clinic setting who are coming in and are pretty adamant about not wanting to be on treatment because of, very reasonable concerns and fears, because they know someone who got chemotherapy for a type of cancer and that person didn't do very well with their treatment or whatever concerns they have. I think it's important to understand that there are different types of drugs. So those fears and those concerns that you still present to your doctor if you've been diagnosed with the cancer, to really discuss some of your concerns and your fears, and also being open to whatever additional information you may get from that visit, but not necessarily making a decision without having a conversation about what the potential side effects could be of your treatment if there are. And so it's not a blanket, treatment for all types of cancers. And you can see, we mentioned that for breast cancer treatment, not everyone needs chemotherapy. Not everyone requires any sort of medication for their cancer. There are breast cancers that we don't give any medication for. So just a comprehensive assessment, I think, is important, but and just presenting with the questions. Next slide. Chemotherapy is only given for terminal patients, and this is obviously a myth. There are many times where, like I mentioned earlier, that chemotherapy is really just medication, and we call it systemic therapy. Systemic therapy is just any drug that goes through the bloodstream, through the whole body, to target where cancer cells may be. And so there are times where we will give chemotherapy in patients with early stage breast cancer, because there's a concern that there may be tiny cancer cells that we need to destroy before they have that ability to spread, years after a diagnosis. There are times where even in patients who have stage 4 metastatic breast cancer, where we actually don't give chemotherapy, where we're able to manage this patients with just an anti-hormone pill or non-chemotherapy drug for many years. So once again, I think it's important to understand that there's no blanket general sort of one way of treating a breast cancer. It's important to know what stage the breast cancer is, the hormone receptor status. Oh, I just got unmuted. Can you hear me? I was muted for a minute. Okay. Yes. So, so chemotherapy is not given just to terminal patients. A patient who's been diagnosed with early stage breast cancer where chemotherapy is being offered, it's not necessarily because the patient is terminal. It's generally because there is a potential for cure at that point. And this myth is that chemotherapy is only administered intravenously, which is that it's given through an IV. That is a myth. Most chemotherapy drugs right now are given intravenously, but there are also chemotherapy drugs that we give orally through pills. The anti-hormone treatments we give are pills. There are chemotherapy drugs that are also pills, as well as some additional targeted agents that are also pills. So not all drugs are IV, because on the flip side, there are patients who are concerned they are being undertreated because they're not getting an IV chemotherapy. And it's important to understand that, once again, treatment really varies depending on the cancer type, and there are different formulations of the anti-cancer treatments that we have available. And I believe this is my last slide. This is a myth that there's no hope for stage 4 breast cancer. Definitely a myth. Stage 4 means a breast cancer that has left the breast or the lymph nodes and now spread to other parts of the body. Certain cancers, when they spread, they go to the bones, they can go to the liver, they can go to the lungs. And there is hope. And we've made such progress over the last few decades, and there's still ongoing progress. If you look at the slide, looking at 5-year survival in young women with stage 4 cancer, in the 1990s, a 5-year survival was about 18% in this patient. By the early 2000s, it had doubled to about 36%, and the numbers continue to improve. And the reason why is because we have better drugs. We know more about this cancers. There's a whole lot of research that is ongoing. And I put the slide on there just to also acknowledge that, or just state the fact that Black women, minority women are generally underrepresented in many of these clinical trials that are leading to groundbreaking discoveries and leading and contributing to our ability to manage patients and treat them for a very long time, even when they're metastatic. So it's important for us to really communicate with our community that being on a clinical trial, if one is available, and clinical trial does not necessarily mean that you have to be on an experimental drug. Just even trials where the type of tumor a person has can be analyzed for additional information to know the best way to manage this patient is really important, because these discoveries are really leading to drugs that are prolonging people's lives. So there's always hope for all types of cancers. I have patients with stage 4 breast cancer 10 years down the line. And so, and there's going to be more and more progress, and it's important for us all to be a part of it. So we're also benefiting from the research.
Yeah. Great. So I'll jump in now and just talk about radiation therapy a bit. So just to start off, what's radiation therapy? Basically, it's the use of, I say X-rays. They're kind of a little bit more powerful than X-rays, but we're aiming invisible energy towards the breast to try and destroy any cancer cells that can't be, seen with the naked eye or seen on a mammogram or a CT scan. So it's usually giving after surgeries, and that's what we're calling radiation therapy. So the first myth is that radiation therapy is painful. So many women come to me and they're worried that they're going to feel daggers, in their breast while they're getting radiation. But the truth is that you can't feel, see, or hear radiation. The side effects over time of the treatments can cause pain. There can be swelling, there can be there can be breast pain, a little bit of discomforts, but on a daily basis, which is usually how often we give radiation, you shouldn't be feeling, painful, like pins and needles inside your breasts as you're receiving radiation. So I'll go to the next one. So the second myth is that it'll make you radioactive. So, you know, Halle Berry storm with all the energies. Unfortunately, that's not what I'm going to do for you. I am going to do my best to, you know, take care of your cancer, but usually radiation therapy for breast cancer is not going to make you radioactive. With external radiation, you shouldn't be radioactive. There's radiation for other kinds of cancers. Sometimes you'll hear of men who have prostate cancer that get radioactive seeds put inside the prostate. That can make them radioactive for a certain period of time. But when it comes to breast cancer, usually those treatments do not make you radioactive. We're not implanting seeds that will stay there forever. So next slide. All right, radiation therapy. Oh yeah, I think we talked about this, so we can move on to the next slide. Okay, radiation therapy will burn me. So this is the most common one that I get. And you will have skin reactions, right? Some people will sail through radiation and they won't notice much, if any, change. But most people will notice some darkening of the skin, maybe some redness of the skin also. In certain cases, there will be a peeling that happens. But you know, like when you get like maybe when you touch an iron with your hand and that part peels off because it's a burn, or you burn your hand on the stove. In most cases, that should not happen. Sometimes there will be peeling, especially if we're aiming the radiation and there's some like areas where there's skin folds, like the skin is folding on top of each other. Those are areas where the radiation dose can intensify, and that can lead to skin peeling. But the radiation is not across the board going to burn people. Also, we're going to prescribe certain things. Next slide, please, to help you take care of your skin. These are things like skin lotions that should help decrease the risk of severe side effects. Radiation therapy will make me lose my hair. Unless we're aiming the radiation at your head, it should not make you lose your hair. So if I'm treating you for breast cancer, it's like surgery. It's focused on where the cancer used to be. So we shouldn't make you lose your hair there. Now, let's say we found some lymph nodes that had cancer. If I'm aiming in your armpit, then you will lose your hair there. But in general, radiation isn't known for making you lose your hair on the level that, you know, some chemotherapy drugs might. Okay, next slide. Next slide. So radiation therapy will increase my chance of developing more cancer in the future. So some people worry because when we hear about radiation, we think about, you know, things like Fukushima or some disasters that happened that caused people to develop cancer. But those were like uncontrolled instances and accidents where the doses were not, you know, much higher than what, you know, a normal person should get. We've studied radiation therapy for over, you know, almost 200 years, and we've learned what are the doses that your body can tolerate. And we know that the chance of a second cancer is usually very low, less than 0.1% for most cases, unless you have you know, some kind of familial predisposition to certain cancers. But in most cases, for most people, you have a very low risk of getting a second cancer, and the benefits of radiation therapy far outweigh the risks of you developing a cancer. And usually that cancer will develop 10 or more years down the line from radiation. But discuss with your doctor the concerns that you have about maybe getting a second cancer, but more than likely it's negligible. All right, next slide, please. Okay. And so radiation therapy will cause nausea and vomiting. So usually if we're not treating the brain, the stomach, your bowel or your liver, you should not be having nausea. So radiation to the breast usually will not cause nausea and vomiting, okay? And if you are getting radiation to other sites, let's say we're treating somewhere in your pelvic area because of the cancer has gone there, and we're treating some of your intestines, we have medications we can give you to decrease your nausea. So these are the common side effects of radiation, right? Feeling tired, skin changes, you might have breast swelling, some breast pain, and in rare cases, if we're treating, let's say we need to also treat the lymph nodes, there's a potential side effect of developing a cough, like because of irritation of the lungs, but that's not very common. So the top 4 are the more common side effects of radiation therapy. Okay, and these are just some of the remedies that we might suggest for you. Rest. If you're able to exercise, exercise. To take care of the skin, we'll recommend something called aloe vera or calendula lotion. If the breast is feeling very sensitive, swollen, we may advise you to try Advil, Tylenol, or some cool compresses. And then remember the cough, if that happens, you might need to be placed on steroids. So I think that's it.
Thank you, Dr. Balogun. So this is our last slide, and it's a reminder, and by the way, we have some questions that we're going to address, but that we do have a breast health series to really answer throughout the year, not just during breast cancer awareness, how you can have and maintain healthy breast. And so here's the list, and then let's address some of the questions. So Dr. Balogun, the question for you is, can radiation cause lymphedema if the cancer was in the lymph nodes?
Yeah, so lymphedema is a swelling, of the limbs. So radiation, so surgery has a certain risk. Surgery increases your risk of lymphedema. So basically why, right? The lymph nodes that we're taking out, that we're sampling, they're responsible for circulating fluid throughout your body. And if we take them out, then that fluid circulation is impacted. So surgery has a certain risk of increasing your risk for lymphedema, the swelling of the limb, and then radiation also can increase your risk of that lymphedema. So both of them together, if you get not just one or the other, but both of them together, that has an even higher risk than either one alone. But I think the risk is around like 20 some odd percent, like it's 20% or so. So it's not that every single person who has a surgery or radiation is going to have a swollen limb. It's just that it may increase the risk. And the best thing you can do is watch yourself. You're your best advocate. If you notice like swelling in your fingers or your wrist, the sooner we can intervene, the better your outcomes and the likelihood of us getting your arm back to normal.
And then there was another question for you, Dr. Balogun, and then I'm going to ask Dr. Taiwo a clinical trials question because there were a couple that came in. And then we're going to announce the gift card winner. So the question for you, Dr. Balogun, is, yes, it's the microwave question, but where did it go?
I see it. From Victoria Lynch, do microwaves increase your risk of breast cancer? So great question. I think this has been looked at. We're now in a technological age. People are concerned. There's been no connection between microwaves and increased risk of breast cancer. So I still wouldn't, necessarily just expose myself to a microwave all the time or stand in front of it. There are other places you can stand. But if for some reason you can't go anywhere else and you have to stand in front of the microwave, there is no indication that it increases your risk of breast cancer. Okay.
Fantastic. And go ahead, Dr. Taiwo.
A couple questions. Yeah, there are a couple questions about clinical trials. So there's one from Evelyn. She said, when a patient is placed with the study group, should they or their insurances be charged? That's a very good question. So there are different types of clinical trials that exist. There are trials sometimes where the trial is looking at how standard of care leads to what the outcomes are when patients are being treated by standard of care. So if we're not doing anything different, sometimes it's just the standard billing to a patient's insurance company. There are clinical trials where there are new drugs that are being assessed or drugs that are being, assessed in a different way than how they're being used traditionally. And in many of those clinical trials that are pharmaceutical clinical trials, those pharmaceutical companies will cover the cost of the drugs and not charge the patient's insurance. But patients on clinical trials should not be charged. They're never charged for being on a trial. It's either the insurance company or the drug company, depending on the clinical trial. So that's usually not a concern. I think it's important for patients to understand that if you are in a clinical trial, it's actually access to not better care, but just because there are lots of questions that need to be answered, lots of assessments that need to be done while a patient is on a clinical trial, that there is a slightly more attention to that patient, because it's important to make sure that the trial is not leading to any adverse outcomes. So I don't know if that answers your question, but yeah. Generally, a patient is not charged, and insurances will only be charged if the treatment is standard treatment. And then the other one was asking about clinical trials for DCIS for survivors. There are all types of clinical trials that are available. There's actually a website called clinicaltrials.gov. There are thousands and thousands of trials that are listed on there. I mean, I don't know half of the trials that are available. I know what we have at our centers. I know what are available in some of the centers in New York City. But if there's a specific clinical trial that one wants to know about, one can actually go on that website. So if you have, you have an oncologist, I think those are good questions to ask if there are ongoing clinical trials where you live that one may benefit from or contribute to. But I'm sure there's something.
And that's very useful. And I'm also going to drop another website to look at based on a direct question or message that came to me about a gene mutation and when to know basically what the recommendations are as it regards or as it relates to bilateral mastectomy versus surveillance with mammogram and MRI. And so we often hear BRCA or BRCA gene as being a common gene mutation, germline gene mutation, but there are a ton of others. And I shouldn't say a ton, but there are definitely others. And the NCCN, which is what we follow, can really lay out for you really what to expect if you are found to have X, Y, and Z gene mutation. And so look at that if you have questions. Now, oftentimes what should happen, and doesn't always happen, but when you get genetic testing, you should have a genetic counselor who goes through all of that with you and basically gives you a risk assessment of your likelihood of developing breast cancer or any other cancer for that matter based on the gene mutation or even the VUS. So I will leave it at that. And there was one more question about how would you know which clinical trial to participate in? That's a great question.
That's a very good question.
Yeah.
And I mean, that is a question to be asked to your oncologist if you do have breast cancer. There are different clinical trials that are available. There are certain breast cancers where the treatment is pretty standard. There's no clinical trial available because we know that there's not a whole lot that in terms of questions that haven't been answered about certain cancers. So there may be no clinical trial for those types of cancers. So I think it really just depends on what kind of cancer you have. And so that's a great question. Every person who knows a person who's been diagnosed with the cancer or who's been diagnosed with the cancer, part of the initial assessment should be, are there available clinical trials for this cancer that I have? And that oncologist should be able to guide you as to if there are trials and if that person is actually a great candidate and eligible for the trials that exist.
I think that we have to just take a moment because what you're saying is very powerful. And I think, it's easy for us to know, but if our community doesn't understand or not aware that actually clinical trials can empower you and also provide you with access that you would normally not, you wouldn't otherwise have. And meaning access, meaning eyes on you, right? And eyes on your cancer, because guess what? They want their clinical trial to do well. Everybody wants their clinical trial to do well. And so, you know, it's basically like a concierge. Most clinical trials are like a concierge, you know, service where you have that access that you would not have normally had. And I should just mention this because I just thought about it. I have family members who have autoimmune issues, and so my family's from DC. And the NIH is there, and just growing up knowing that we had the access to just free stuff and having extra eyes and tests and all of that. Recognizing though that there is a historical context that we cannot ignore, and we certainly understand that mistrust and would never, say put that to the side. We know that where we treat patients and the institutions that we align ourselves with, we are sitting at the table. We are serving as a voice for communities, for minority communities and otherwise. In that, we wouldn't recommend something to you that we wouldn't recommend to a family member. And it's so important that also, as we make treatment recommendations, like Dr. Taiwo said, we cannot just make it general and say, because this medication worked in this particular population, that it's going to work in Black women, and so, we need to just really represent and be available so that it's generalizable in that way. Anything else, ladies?
No.
Okay, yeah, I think this is great. All. This was great. So I had fun. This was like no other presentation this month because I have my girls, my colleagues who are wonderful. You're very welcome, LaTanya. I think now we're going to have our wonderful student who is working with us on the Sister Give Me Your Hand project introduce the gift card winners. Did you want to say something, Placette or Princess? We can't hear you.
Thank you guys for a great presentation. That was really great. I love this whole pink table talk where we get the opportunity to just ask questions and hear from you guys. I just wanted to say, apologize too for the technical difficulties when we got started, but also just to remind you guys that Sister Give Me Your Hand is a project geared towards African-American women. We thank you so much for coming on this call tonight. We have a couple of other series coming up soon. The next one will be in January where we're talking about sexual health and cancer. In March, we'll be talking about nutrition, hair, and nail care. In May, we're talking about Black women and mental health. So we really hope that you stay on our mailing list, stay connected with us so we can continue to share information with you. And also, we are doing a survey to understand barriers to breast cancer screening for African-American women. So if you haven't already completed our survey, please do. You can reach out to myself or Frances, and when we're done, we'll put the slides up so that you can see how to access the survey. And the important thing about this project is Breast Cancer Awareness Month. We all wear pink. There's pink everywhere. And to some degrees, when you think about marketing, it's been saturated so much with pink. But the real issue is what we're doing here tonight. Like over 60 of you have joined us tonight to talk about breast cancer myths and facts, because there's so many myths and facts that inhibit us from getting screened and getting the proper care. So this type of talk is really important. The next time we have a talk, please share. This is our first time, one of our first times successfully streaming live on Facebook. So please friend us on Facebook and all social media. Look for us at Sister Give Me Your Hand in Brooklyn and also in Camden. The survey that we're doing, it takes about 20 minutes to complete. We administer the survey. You cannot do it by yourself. And we thank you for your time. We offer a $20 gift card to Walmart or Target. It's really important for, it's not the same as clinical trials, but it's just really important for Black women to be a part of the conversation about the barriers that impact our lives. So if you haven't already done this survey, please reach out to us. The survey is for Black women 40 and older who have never been diagnosed with breast cancer, who live in Brooklyn and certain counties in New Jersey, just Camden and Burlington counties in New Jersey. And then, you know,
let me just ask you this, Lisette.
Yeah.
Can they use their phone and scan a QR code?
Yes, so we have the flyers up that we, Francesca will share right now, and you can scan it, and then it'll link you to the survey, and you'll give us your name and phone number, and we'll contact you to do the survey. And before everyone departs, we usually give out gift cards while Francesca is bringing up the slide. I wanted to let you know that we have one winner. Her first name is Alana, last name is Akong. So thank you so much for participating.
Oh, thank you.
You're welcome. You have won a $25 gift card. Do you live in New York or New Jersey?
New York.
Okay, so your gift card will probably be for Target. So thank you so much for participating.
Thank you so much.
Yay. I want everybody, before you sign off, sorry, said I want them
Wait,
to...
one more thing, Alana, please give us your contact information. If you can put it in the text, I sent you a private message, if you can respond with your contact info. And that's it. Thank you all. Thank you, Dr. Bea.
All right, take out your phones. Where's the QR code? I want everybody to take an opportunity, because we have to hear from you. We need to know what the barriers are, how we need as clinicians and physicians to help, help provide the access that is necessary. So if we can make that screen bigger, there you go. Scan that code. I don't see any phones out. Where are the phones? Scan that code and register. Okay, I see a few phones. $20. Let us hear from you. This is an opportunity for us to, let me just say, this is supported by American Cancer Society. So they understand that, all communities need to be heard from. And this is an opportunity to let your voice be heard so that we can develop future programs in our communities that really assist with addressing access issues and other issues. So phones out. Okay. And then the other thing I will mention is that we do have extended hours in New York Presbyterian Brooklyn Methodist Hospital for mammograms every first and third Mondays and Wednesdays. And this is we're trying to really improve access to mammograms for women who, can't take off during the day. So this is a way to really address that barrier. And then again, there's going to be a $25 gift card raffle at the next event. And I'm going to silence my computer and all of that. Thank you for coming.
Thank you for having us.
Thank you all. Good night.
Good night.
Thank you. Good night.
Good night.
Great job, guys.
Good night.
Good night.
Good night. Thank you.
Thank you.
Great job.
Good night, ladies. Great job.
Good night, ladies.
Have a nice evening. Great job.
Thank you.
Learned a lot. I let you miss a good meeting.
Alana, if you're still on, I don't know if Frances has your contact information, but please.
I thought I sent it. I must have sent it to the wrong person.
Okay, maybe you sent it to Ashley, or you sent it to Ashley Brown or Frances?
I don't think so. Let me just send it again. I'm struggling over here. Hold on.
It's okay. It's okay.
I'm
going to put my email address in the chat as well.
That's helpful. Yes, I'll do that. I'll email it to you once you send it through email.
Okay.
Here we go. Okay. Copy. All right. I'll go ahead and email you now.
Thank you.
Thank you. All right. Have a good one.
You too.
Bye-bye.
Great job, Placette and Princess. Can't hear you, Mama.
You guys did a great job too. So that was really. You still can't hear me? I'm talking into the phone.
No, it's me. It's me. It was me. I muted you. I had a patient call.
Oh, okay. That was really good, and this was a crazy setup because we usually are on 30 minutes before, so but this went well despite that.
Yep, it sure did. You guys did an awesome job, so pat yourselves on the back. This is outreach. I love it. I love it, love it, love it. Okay?
Yeah, you good. Princess said you had a birthday coming up. Happy birthday. So thanks for doing this.
Thank you. Absolutely. It's my pleasure. I like Thursday nights. This was good.
Okay, good. Okay.
Good. Okay, my dears.
Princess, Princess, are we staying on to debrief?
Yes, please.
Do you want to release the others who are?
Yeah, I'm trying to.
I'm helping you.
Okay, thank you.
Right. I'm trying to.
Okay.
Bye, y'all. You don't need me.
No,
you're good. Happy birthday.
Thank you. And Princess, I'm so sorry I stood you up. It was not on purpose. It really wasn't.
Don't worry about it. Enjoy your weekend.
I looked at my calendar and I was like, oh, I have meetings virtual. I'm not going in. We'll reschedule, okay?
All right. Have a great weekend. Happy birthday again.
Thank you.
Yeah.
All right. Thanks, Dr. B.
Okay. I'm trying to get this thing to stop recording.
Same here.
Let's just hang up and talk on the phone.
Okay.
Yeah. Wait, I think Ashley got off, but I'm pretty sure she said she captured